Good evening, everyone. I'm meeting today to go over New Horizon in treatment and type 2 management. My name is Dr. Jalal Nafach. I'm a consultant endocrinologist in Dubai Diabetes Center, Dubai Health Authority. I'm honored and privileged to have Dr. Verna. He is a world-renowned cardiovascular surgeon. He is the current Canada Research Chair in the cardiovascular surgery. He is Professor of Medicine at the University of Toronto. He published extensively in multiple journals, including New England Journal of Medicine, Lancet, and Circulation. And today we'll have a great meeting that actually we're going to start by discussing GLP-1 as a treatment, having a new formulation that's oral GLP-1. Then Dr. Verna will give us spotlight on the glycemic management in type 2 diabetes and cardiovascular disease. And then I'll be interviewing Dr. Verna on the treatment barrier and the practical consideration in the management of type 2 diabetes. And then in the end, we'll have a panel discussion and closing remark. At this, I'll start my part in going over GLP-1 treatment. Again, the title is Oral GLP-1 and the Incretin Landscape. It's expanding the treatment. Now we have a totally different formulation that will help us achieving better glycemic control and, of course, trying to reduce the cardiovascular disease in the population. Initially, we're going to go over introduction, the oral semaglutide. Then I'm going to go over the Pioneer program, which is the clinical program. And then we'll discuss the efficacy and safety, and later we'll shed light on the dose consideration. Now, what's about oral semaglutide? We have to remember that in patient with diabetes, we have multiple abnormalities, including, for example, decrease in the beta cell function, decreased insulin production, insulin resistance, increased glucagon secretion, increased glucose production by the liver, increased glucose reabsorption by the kidney, and so on. So you have multiple abnormalities, and that's one of the problems we always have to face when we treat type 2 diabetes, that we need to look at combination therapy to try to attack as much abnormalities we have that contribute to the patient hyperglycemia. And what's unique about GLP-1 as a class first is the ability to affect multiple abnormality, including reduction in the beta cell function. It has an effect, of course, in suppression of glucagon secretion. That's glucose-dependent matter. So there is no risk of hypoglycemia, and there is no risk of loss of sensitivity to hypoglycemia. It has an effect, of course, on decreased appetite, slow gastric emptying. It will suppress, of course, will have an effect on gluconeogenesis. So actually it attacks most of the abnormality we see in type 2 diabetes. Now, again, one thing we always have to look at is if we compare DPP-4 to GLP-1 to SGLT2, again, SGLT2 will affect mainly the glucose reabsorption by the kidney. DPP-4 mainly will affect much or less the beta cell function in a sense of decreased beta cell function. It suppresses glucagon, but it will not have effect on the other factors. It would not have an effect on decreased stomach emptying. And so you don't see this potential effect unless you use a stronger agent, i.e. GLP-1. And if you look at it actually in this slide, you can see very clearly that by using DPP-4 inhibitors, actually what we're doing, we're allowing the human GLP-1 to go to somewhat similar or twofold of the normal physiological level of GLP-1. And that by itself would not cause the effect that we're looking at, i.e., for example, weight loss. And it actually needs a higher level or supraphysiological level of GLP-1 to have the decreased appetite, the decreased food intake, and the weight loss on top of better glycemic control. So there is kind of, if you want to call it a threshold, between using DPP-4 inhibitor and using GLP-1 agonist. Now, talking about that and seeing how important is to look at GLP-1 in the management of our type 2 diabetes, knowing it affecting multiple abnormality, it's also, we have to recognize it is different than the DPP-4 inhibitor. But not only that, there is a difference between the different GLP-1s. Some GLP-1s are long-lasting, some of them are shorter acting. Some of them have a bigger molecule, some of them will have a smaller molecule. Of course, having a smaller molecule, it may be beneficial because it can cross the brain barrier and you tend to be able to see more or further weight loss. And then on top of that, there is a difference between being GLP-1 based or Incretin based. And of course, that will have an effect also on the homology to the human GLP-1 and the possibility of producing antibodies that actually could interfere with the effect of the GLP-1 agonist you're using. So I mean, again, we have to remember that they're not all the same, and that's one thing to remember. And if you look at this slide, again, you can see that we have an Incretin-based therapy. Again, we have the exenatide twice daily, then we have the weekly, and then lixazenatide. When we come into the human GLP-1 based therapy, again, we have liraglutide. Again, liraglutide has been the gold standard GLP-1 for many years. You have dulaglutide, and you can see here that the molecular weight of the dulaglutide is heavier. And then semaglutide, again, is a smaller molecule, and this is the one we're going to shed light on. And now, again, we're very excited that we have an oral formulation of the semaglutide. Now, the problem we always have using GLP-1 therapy, being a peptide, is the problem is multiple fold. Number one, we tend to see a degradation by the enzyme in the stomach, and then there's also limited permeability, and that, of course, it will lead to significant limited bioavailability, typically somewhere in the range of 0.01%, so almost no absorption whatsoever. So to combat that, we have now a new formulation of the semaglutide that we know of it, that's the most effective available GLP-1 in the market, and a SNAC, which is absorbent enhancer. And what it does is actually increase the absorption, increase also local pH, and thereby hence decrease the degradation of the product and allow to have an effective and pharmacological level of the GLP-1 after oral administration of this product. And again, we have to remember it contains semaglutide. Again, it is the most effective GLP-1 we have right now. It is the first oral GLP-1. And again, looking at the studies using oral GLP-1, semaglutide comparing to the subcutaneous, you're actually, with the oral formulation, you're going to be able to have the similar exposure response. Now here we see this big slides going to American Diabetes Association guidelines, and I'm going to go over a portion, but again, I'm sure you've all seen that multiple times. Again, the American Diabetes Association published their guidelines every January, and the difference now that you can see is when we look at patients who have established disease or even who have very high risk, including those who are older, over 50, 55, those who have even a sign of carotid stenosis, patient with LVH. This is all considered a high risk population, and those we have to look at using diabetic agent to lower their cardiovascular risk. And we have to understand that we have to do that irrespective of the hemoglobin A1C. And if you have, for example, a patient who's well controlled on a different agent that does not offer cardiovascular safety, you should consider switching even if the patient is well controlled, because again, you're trying not only to get the glucose down, you're trying to reduce their cardiovascular risk. And of course, here we have the two classes that we shown benefit, which is again the GLP-1 and SGLT2. If heart failure is the presenting problem, then typically SGLT2 tend to offer more benefit in that perspective. And then if a patient have chronic kidney disease with proteinuria or a GFR below 60, then again we have to consider those agents, i.e. SGLT2 and GLP-1. Now, if the only aim is to reduce hypoglycemia, then again we have the option. And again, this is in the group of population that are not high risk, or don't have established disease, don't have renal disease, and don't have heart failure. And this will include, of course, DPP-4 inhibitors, GLP-1, SGLT2, and TZD. So this is the options we have that will avoid the patient from getting hypoglycemia. And of course, if cost is an issue, sulfonylurea and TZD will be, of course, the first less expensive options. Then you follow that by using insulin therapy. Now, if we're looking to achieve more weight loss, then again, the two most effective agents that help with weight loss, again, GLP-1 and SGLT2. One thing we have to remember is that not all GLP-1s are the same in a sense of weight loss. Again, semaglutide is the most effective GLP-1 available in the market right now, and the most effective in a sense of a weight loss, and that's something to keep in mind. Again, you do not want to use it as a weight loss drug in the diabetic. It's actually a diabetic medication on top of the benefit of the weight loss. And of course, SGLT2 will offer also benefit in weight loss in those populations. Now, when we go over the Pioneer program, we have to remember that this is a very unique program that look at the efficacy and the safety of using oral semaglutide. And the program has very similarity that include the 3 different formulations. So usually there's titration phase, and so it start with a 3 milligram daily, and then follow to the 7 milligram, then the 14 milligram. Now, always in this program, you start with a lower dose, and then 4 weeks later, there's a titration. And that's again to reduce the risk of gastrointestinal side effects. It's a very big program, so it includes 19 clinical pharmacology trials, phase 1, phase 2 trial, and 10 phase 3 trials, and those include over 9,500 patients. Of those, 5,700 were taking the active semaglutide. So it's a very big program looking at really at the efficacy. Again, you remember that we already have strong data on the injectable semaglutide, but again, they look to prove it again using oral formulation and having such a extensive clinical program to show the efficacy of this. Now again, the Pioneer program has multiple trials. So the Pioneer 1 is the first one you see here, and this is again comparing to mainly placebo diet and exercise. And this is a shorter program. It's totally unethical to continue given placebo in treatment on diabetic. So it's only 26 weeks program. And then we have the Pioneer 2, which again will go over it and it comparing to empagliflozin. Pioneer 3 comparing to DPP-4, and in this case here sitagliptin. Pioneer 4 comparing to an injectable GLP-1, liraglutide. Again, why liraglutide? Because this is the gold standard. It's the same way when you look at all the trials of GLP-1, it always compared to liraglutide. And then Pioneer 7 is actually looking at the flexible dose adjustment, and it has an extension. And then on top of that, we had extra programs, which is looking at moderate to renal failure. Pioneer 6 looking at the cardiovascular safety of the oral semaglutide. Again, we already have a study on the injectable semaglutide. And then Pioneer 8 looking at, again, the efficacy of adding oral semaglutide to insulin therapy. And of course, that will be important because in clinical practice, we're going to have a different variation of patient. And so they try by this program to look at the different combination and the different possibilities and how does it compare to any other treatment. At the end, you as a clinician, when you're going to look at the patient, you're going to decide which agent you're going to use, and it'll be important to know the difference between the agent classes, the difference in the efficacy, the difference in the A1C reduction. It would not make sense to use an agent that's unlikely to get you target. Of course, if you have a patient who's uncontrolled, if you have an agent that would not get them below the target, then it would make more sense to choose a better alternative. Now, one thing again about the Pioneer program is, again, in any program you have a primary endpoint, and then the vast majority of those trials is the same. So the primary endpoint in the Pioneer 1 through 5 and Pioneer 8 was again the hemoglobin A1C reduction or change. Pioneer 6 being a cardiovascular safety trial, again, it looked at the time for the first 3-point MACE, again, myocardial infarction, stroke, and cardiovascular death. And then Pioneer 7, it was looking again, as we talked about, the flexible studies, and they're looking at the proportion of patients achieving hemoglobin A1C below 7%. And again, there was other secondary points, including change in the body weight. In Pioneer 6, it was the time for the first expanded composite CV endpoint, and then change in the body weight in the Pioneer 7. Now, what's about efficacy? And all I'm going to ask you to do is actually look at the slides. And you can see very clearly that here, looking again, in all this trial here, we're looking at the 26 weeks, except the Pioneer 7, which we're looking at 52 weeks. But you can see here very clearly that the column that shows the further A1C reduction is the dark blue color, which is mean the semaglutide oral 14 milligram. So you can see here by a glance that if I compare this to monotherapy, of course, if I compare this to empagliflozin 25 milligram, sitagliptin 100 milligram, liraglutide 1.8 milligram, or comparing to placebo in renal patient, or compared to placebo to add to insulin, or compared to sitagliptin in the Pioneer 7, you are superior to all those options. And this is one thing to keep in mind. And even if you look at the end of the treatment, or look at the 52 weeks in the majority again of those trials, except Pioneer 3, you can see that you're able to maintain superiority in the hemoglobin A1C versus those other classes. It doesn't lose potency as you may think. Now, of course, what that will translate is give you a higher percentage of ability to achieve a hemoglobin A1C below 7%. Now, you have to remember, I mentioned earlier that whenever you choose a treatment, you have to choose a treatment that's most likely to get you to target. And again, for an example, if you look at the Pioneer 2 and you compare this to empagliflozin, patient had a baseline A1C of 8.1, and by using the oral semaglutide 14 milligram, your 67% chance to be in target and 40% chance to be in target with A1C below 7% with the EMPA. And again, that will apply the same if you compare to sitagliptin and this cohort done. So one thing you always need to remember is what the baseline A1C for the patient, what's the possibility of my treatment to achieve the target I'm looking at, for sure. And then if you look again at the end of the treatment, or 52 weeks again, except the Pioneer 3 in comparing to sitagliptin, which was 78 weeks, again, you are much more likely to be in target. And again, if comparing to empagliflozin, 66% versus 43%, compare to sitagliptin, compared to liraglutide, 61% versus 55%. And again, even by adding it to insulin, you are going to improve the likelihood to be in target versus insulin titration. And so you're 54% versus 9%. So you can see that this efficacy is again maintained throughout the trial till 52 weeks in the majority of those trials. Now, what's about weight loss? Again, you can see here very clearly that the oral semaglutide has superiority in the weight loss. And so again here, if you compare to monotherapy, of course, compared to empagliflozin, there was very marginal change, but there is more change if you look at the completer of the drug. In the Pioneer 3 comparing to sitagliptin, of course, it was superior. It had a more weight loss reduction compared to liraglutide. And again, you can see that over and over. So again, in all the Pioneer trials, you can see very clearly that you had such a robust data on the hemoglobin A1C and on the weight loss. And again, if you look at the weight loss at the end of the trial, which is 52 weeks, again, except Pioneer 1, which was 26 weeks, and Pioneer 3, which was 78 weeks, again, you can see a meaningful weight loss. And at the end of the day, here we're looking at that data as anti-diabetic agent and not as weight loss agent, but to have the nice weight loss reduction on top of that. Now, what's about safety? Of course, whenever you use a drug and it looks to be more effective, you always have to doubt, do I get anything in return? And actually, if you look at, for example, the most common side effect you looked at in GLP-1 is really gastrointestinal symptoms. And you can see again here in dark blue, if you compare, of course, to monotherapy, you are going to have more gastrointestinal symptoms. Here again, 16% versus 6%. If you compare to EMPA, 20 versus 2. But again, if you compare to liraglutide, it's very, very comparable. And then when you add it to insulin, you get at the highest dose 23% versus 7% on patient taking insulin and placebo. So even in the arm who take placebo, always there is some patient or will complain of GI symptoms. So at the end of the day, when you see a patient and you start the treatment, few things we have to do. First, we have to sit with the patient and discuss the treatment option. And of course, outline why we choose, for example, oral semaglutide. So that's very important. We have to discuss with them about the gastrointestinal side effect. It is a side effect that does exist. You're not going to be shy about it. We have to explain it does exist. It does goes down over time as the other GLP-1s. We can do things to reduce this side effect, including eating small, frequent meals. Of course, you have a treatment that slows down gastric emptying. You should not eat a larger meal, of course. You should avoid fatty, greasy meals. And there are things like this that you can do, or eating crackers, that will help in limiting and minimizing those GI symptoms. And eventually, patient symptoms anyway will improve and they can tolerate very well. And so this will be very important. And of course, you have to explain to the patient that if you get significant and severe symptoms, you have to seek back your physician and not just fluff it up and continue to take that treatment. You may reduce the dose back. Let's say you titrated the dose from 7 to 14, you can go back on the dose. Now, what's about serious adverse event with the oral semaglutide? And again, you can see here very clearly that if we compare, for example, semaglutide to sitagliptin, again, we as a physician, we like to use DPP-4 because it's no-brainer, it's easy, there's no much side effect, we don't have to think about too many things. But again, you can see here really there is no difference of serious adverse event, and that's the same apply to liraglutide, apply even to placebo if you compare when you add it to insulin. So individual who took semaglutide and top of insulin, and those who did not really have almost the same incidence of adverse side effects. So there's not significant or worrisome sign of increased severe side effect with those patients. Now, what's about retinopathy? Retinopathy is an important factor because there was a concern using injectable semaglutide that there was an increase in the incidence of retinopathy. And by doing the post-hoc analysis of those trials, it seems to be very clearly that that seems to happen on those who have a pre-existing significant retinopathy, especially those who reduced the hemoglobin A1C significantly. Of course, it was reduced significantly because injectable semaglutide was such an effective drug. And so if you have a patient that has a retinopathy that's moderate or severe, for example, you may want to consider, even if you use insulin therapy, you want to reduce the glucose slowly. And if you're going to use oral semaglutide, I may prefer to use the titration slower, allow the glucose to be reduced at a slower pace, and that will decrease that chance. Again, we know very clearly that if we have significantly elevated hemoglobin A1C and we reduce it very fast, there is increase in the incidence of worsening retinopathy initially, then a slowdown. And of course, the most important factor to remember is reduce the glucose slowly in this case. And if I'm using oral semaglutide, then I may prefer to use the titration slower. Now, what's about mycotic infection? Again, with the mechanism of the drug, there's no increased risk of mycotic infection. That's not the case with empagliflozin, again, in the Pioneer 2. And then, of course, you don't see increased urination because, again, it has no effect in a sense of decreased glucose reabsorption. Now, what's about hypoglycemia? Of course, this is one of the adverse events to look at. You have to remember the mechanism of GLP-1. It has multiple mechanisms, as we've seen earlier. But again, the insulin secretion and the glucagon reduction are both glucose dependent, which means there is really very low chance of hypoglycemia. And you can see that very clearly that, for example, to give you an example, in Pioneer 3, comparing to sitagliptin, the incidence of hypoglycemia was exactly the same. Of course, with the fact the oral semaglutide did give you better A1C reduction, more glucose reduction, weight loss. If you compare it to even patients who received placebo, for example, and you add it to insulin therapy, there was no increased incidence of hypoglycemia. So even though in the trials they were able to add semaglutide to insulin therapy, they were able to achieve a better glucose control, lower weight, with no increased risk of hypoglycemia. And that again stands for the safety of such a treatment. So at the end, if you want to summarize the safety, if you look at the tolerability, it's similar to the other GLP-1s. We can do things to minimize this. And then if you look at the other severe adverse event, there is no difference between this and other classes. If you look at the hypoglycemia, again, there is no difference between this and DPP-4 or even placebo, as I showed you. It is, from a safety perspective, very positive signs we can see from all these big trials. Now, what do we do to dose it? Well, typically, again, we have to remember that it has to be done a certain way. So the patient, when they wake up in the morning, they have to take the tablet of oral semaglutide with mainly half a glass of water. It has to be 120 cc of water or less. It should not be more. And then they wait 30 minutes before they take any oral medication or before they eat. And then they're good to go. Now, how do you start? As I mentioned earlier, and as they did in the clinical trials, you start with 3 milligram daily. You do it in the morning. You do that for 4 weeks. At the end of 4 weeks, you can titrate the dose up to the 7 milligram, and again, you do it daily for 4 weeks. At the end of that period, you have to look at the patient glucose control and then make a decision if further advancement in the dose to the 14 milligram is needed, or you would just be satisfied with the glucose control and keep the patient at the 7 milligram dose and then take it from there. At the end, we have to remember what's unique about this drug is we do not need to do any dose adjustment regardless of renal or hepatic problem. And again, that's similar as we see in injectable semaglutide. Again, I showed you that there was a renal safety data done here. There is no dose adjustment in elderly patient, so really don't need to look at that. And again, part of the adjustment in elderly patient, not only they're more sensitive to treatment, big majority of them have renal problem, and here really you don't need to adjust on it. And there is very low risk of hypoglycemia, as I showed you prior to that, even compared to placebo or sitagliptin. So at the end, if I need to summarize, oral semaglutide is the first and is the only oral GLP-1 agonist. It has greater efficacy than the GLP-1 daily here, liraglutide, SGLT2 here, empagliflozin, and DPP-4, sitagliptin. Efficacy across all spectrum in type 2 diabetes, and actually we know that already from GLP-1 that we cannot really predict response based on the duration of diabetes. Safety profile is very similar to other GLP-1 from a perspective of gastrointestinal symptoms. And even if you look at other safety, including, for example, hypoglycemia, severe serious side effect, it is very comparable. And at the end, with Pioneer 6, we had shown and will be seeing the data of cardiovascular safety that's been confirmed very clearly in this. And at this point, I'll finish and I'll move to Dr. Verna. Thank you.